Laura Mertens. I'm an oncologic urologist at the Netherlands Cancer Institute in Amsterdam, and my main focus is the treatment of patients with bladder cancer. The NCCN, the ESMO, and the EAU have all published management guidelines for the perioperative treatment of patients with muscle-invasive bladder cancer. And the current standard treatment for patients with non-metastatic muscle-invasive bladder cancer consists of neoadjuvant cisplatin-based chemotherapy. And this is based on level 1 evidence demonstrating survival benefit after neoadjuvant chemotherapy followed by cystectomy compared to cystectomy alone. So cisplatin-based neoadjuvant chemotherapy. And although neoadjuvant chemotherapy is generally preferred, cisplatin-based adjuvant chemotherapy should be discussed in case of locally advanced or lymph node positive disease after radical cystectomy, if no neoadjuvant chemotherapy was given. Also, nivolumab has been approved by the EMA in the adjuvant setting for specific patients, although it's not available everywhere in Europe. On the one hand, we need more effective perioperative therapies, while at the same time, they should ideally have reduced toxicity and be suitable for patients who are ineligible for cisplatin-based chemotherapy. Well, first of all, even though cisplatin-based neoadjuvant chemotherapy yields a complete pathological response rate ranging between 20 to 40% at radical cystectomy, which correlates with improved survival, the risk of recurrence for patients with localized muscle-invasive bladder cancer still is very high. Also, even in contemporary settings, neoadjuvant chemotherapy continues to be underutilized, and a large proportion of patients is considered cisplatin ineligible, cisplatin unfit, due to frailty, comorbidities, impaired renal function, and perioperative treatment options for these cisplatin unfit patients are very, very limited. There are no standard neoadjuvant systemic treatment options available for those patients, and the rationale of immunotherapy is that it can really expand therapeutic options in the perioperative setting. Many immunotherapy-based regimens are currently under investigation in the perioperative setting for muscle-invasive bladder cancer. This includes immunotherapy, monotherapy, combination immunotherapy, or immunotherapy in combination with chemotherapy, with ADCs, or with novel drugs. And these trials are being conducted in the neoadjuvant setting, in the adjuvant setting, and in the perioperative setting, where patients receive both neoadjuvant and adjuvant treatment. In the neoadjuvant setting, several early phase trials have been performed on neoadjuvant immunomonotherapy. For instance, the PURE-1 trial, which is a phase 2 trial on neoadjuvant pembrolizumab, showing a complete pathological response rate of 42%. The EBAC trial with neoadjuvant atezolizumab, achieving complete pathological response rate of 31%, though among patients with high PD-L1 expression, response rates were higher. And in the adjuvant setting, an important trial is CheckMate 274, the trial which led to approval of adjuvant nivolumab monotherapy. This is a phase 3 randomized double-blind trial where patients were randomized to adjuvant nivolumab versus placebo in case of muscle-invasive urothelial carcinoma at high risk of recurrence after radical resection. The primary endpoints of disease-free survival in the intention to treat population and in the PD-L1 positive population were met. This has been previously published, and just recently the results of an extended follow-up of 3 years were presented. Consistent disease-free survival benefits with adjuvant nivolumab versus placebo was observed in both populations, and the hazard ratio of overall survival with adjuvant nivolumab versus placebo was 0.76 in the intention to treat group and 0.56 in the PD-L1 positive group, and no new safety signals were observed. Other trials in the adjuvant setting include the Ambassador trial and IMvigor010 trial. In the Ambassador trial, patients were randomized to adjuvant pembrolizumab versus observation. Adjuvant pembrolizumab led to a statistically significant improvement in disease-free survival versus observation, meeting one of the trial's primary endpoints. The other primary endpoint, overall survival, did not reach statistical significance at this moment and continues to be further evaluated. IMvigor010 is another phase 3 trial in the adjuvant setting, assessing adjuvant atezolizumab versus observation. In this trial, the primary endpoint, disease-free survival, was not met, and also no overall survival advantage was demonstrated, though patients with ctDNA positivity did show a benefit with atezolizumab versus observation, and this is further investigated in the IMvigor11 trial. In the neoadjuvant setting, several combinations have been tested, including neoadjuvant combination immunotherapy, like in the Nabucco trial, where neoadjuvant ipilimumab and nivolumab were evaluated, as well as combinations with chemotherapy. For instance, the phase 2 SAC-0617 trial, evaluating neoadjuvant durvalumab plus gemcitabine cisplatin, followed by cystectomy and adjuvant durvalumab. Furthermore, there's also the NEMEO phase 1 and 2 trial, where neoadjuvant durvalumab with or without tremelimumab in combination with MVAC was investigated. And then there's the BLAST-1 phase 2 trial, where neoadjuvant nivolumab, gemcitabine, and cisplatin were tested. So several early phase trials, but a key clinical trial worth highlighting here is a Niagara trial. This is an open label randomized trial, a phase 3 trial, where cisplatin eligible patients were randomized to receive neoadjuvant durvalumab plus gemcitabine cisplatin for 4 cycles, followed by cystectomy, and then adjuvant durvalumab for 8 cycles, or to receive standard of care neoadjuvant cisplatin-based chemotherapy, so gemcitabine cisplatin, and then radical cystectomy. Event-free survival was one of the 2 primary endpoints, and overall survival was a key secondary endpoint. The estimated event-free survival at 24 months was 67.8% in the durvalumab group and 59.8% in the gemcitabine cisplatin group. The estimated overall survival at 2 years was 82.2% in the durvalumab group and 75.2% in the comparison group. Treatment-related adverse events were comparable between both groups, and the radical cystectomy was performed in 88% of the patients in the durvalumab group versus 83% in the comparison group. So this trial really shows that perioperative durvalumab plus neoadjuvant cisplatin-based chemotherapy leads to a significant improvement of event-free survival compared to cisplatin-based chemotherapy alone.
I am Professor Tom Powles. I'm an oncologist in London. That's a difficult question because there have been a lot of studies and it depends what you mean by perioperative. So perioperative can be neoadjuvant, adjuvant, or the combination of neoadjuvant and adjuvant. And there have been 3 groups of trials. I'm going to start, if I may, with the adjuvant trials because that's probably where the first data came from. And the most famous data is with CheckMate 274, the adjuvant nivolumab data. So this is for patients who have had a successful operation, they've had a CT scan, there's no evidence of disease. For patients, some have had neoadjuvant chemotherapy, some have not had neoadjuvant chemotherapy, they've just had the surgery alone. Some are cisplatin eligible, some cisplatin ineligible. The patients all have relatively high risk disease. You can see here the median disease-free survival of only 10 or 11 months in the control arm. So many patients who think they're cured here, actually half the patients are progressing within a year. So this highlights the huge unmet need in this perioperative setting. Now, these data showed a hazard ratio of about 0.7 for disease-free survival. An OS hazard ratio of 0.76. That wasn't statistically significant yet. And it showed some enrichment for the PD-L1 biomarker. And that enrichment, I think, has caused more confusion. The EMA's approved it in PD-L1 positive patients. I'm not sure I'm a great supporter of that. I think, for me, the biomarkers come to the end of the road, but that's neither here nor there. The Ambassador study, an investigator-initiated study out of the US, an amazing effort, huge effort to do randomized phase 3 investigator-initiated trials. From a DFS perspective, it showed very similar results to the Checkmate 274 trial. The control arm performing a little bit better, 14 months, showing a slightly lower risk population, but still that significant DFS advantage with a hazard ratio of about 0.7, but here no significant OS. With both of these agents, the adverse event profile is exactly what you'd expect for immune checkpoint inhibition. And I tell my patients about a 10% chance of life-changing toxicity. Now, that without significant OS at this stage, results in people being a little bit anxious about giving this therapy to unselected patients. The next study, which I wanted to talk about, was IMvigor010. It's complicated, I think. It's a PD-L1 inhibitor. I don't think PD-L1 inhibitors are inferior to PD-1 inhibitors in this space. Actually, when you look at the conduct of the trials, I just feel there was a lot more censoring in this study than in the other trials. That's my opinion. The results were trending in the right direction. Again, the adverse event profile was in line with expectations, but a very negative trial. It doesn't have EMA or FDA approval. And the important issue from this trial is some exploratory ctDNA analysis was performed. 40% of patients were ctDNA positive. And of those 40%, it looked like ctDNA was not just prognostic, but also appeared to be predictive of response to immune therapy. So you had about an 8-fold increased chance of relapse if you're ctDNA positive, number one. And number two is if you're ctDNA positive, that earlier atezolizumab, that almost all the patients relapsed, but atezolizumab associated with a 40% reduction in the risk of death. The Niagara study is different. It's a perioperative study. It has that neoadjuvant period and the adjuvant period. The neoadjuvant period is 4 cycles of neoadjuvant chemotherapy with durvalumab, and then a cystectomy, and then 8 cycles of durvalumab. It's a study looking at high-risk muscle-invasive bladder cancer, but it's a very different population from the adjuvant population that have had this big operation and having adjuvant therapy. And some of the diagnosis at the beginning is done radiologically rather than pathologically. So these trials are very different from each other. And this trial showed a hazard ratio for event-free survival of 0.68, but also significant overall survival. And that's the advantage that Niagara has over the other trials within the adjuvant setting, which didn't show significant OS. It also showed a 10% increase in pathological CR rates, which is underpinning the importance of that neoadjuvant period. And finally, from a safety perspective, there was no higher risk of surgical complications, no higher risk of not getting or not having surgery, no overall higher risk of adverse events associated with the addition of durvalumab to chemotherapy. So I think that's a positive signal. And in my opinion, that data set is attractive because you're getting the immune therapy in really early. Of the 3 interventions, chemotherapy, surgery, or immune therapy, I think it's the immune therapy that's the easiest to give. And I think immune therapy, as we know, is the drug associated with long-term durable remission. So for me, that's become an attractive approach for muscle-invasive urothelial cancer. If we focus on biomarkers in the perioperative setting, that's the neoadjuvant and the adjuvant period. I think it's fair to say, to start with, we don't really have any reliable tissue-based biomarkers. I think it's fair to say that circulating tumor DNA, particularly in the adjuvant setting, appears to pick a group of patients at low risk of relapse. But the role of ctDNA in neoadjuvant patients is yet to be identified. So ctDNA may be the most promising for the adjuvant patients, but the perioperative patients, we don't yet know enough about it. There's a study called INVIGOR-11, which is looking at ctDNA positive patients who get atezolizumab or placebo post-surgery, and that's a really important study. I think that's very exciting. When one looks at the neoadjuvant period, it's more complicated, in my opinion, or actually just less convincing. It doesn't look like any of the immune biomarkers are consistent. So PD-L1, TMB, CD8 have been inconsistent in this setting. And it doesn't look like we have any chemotherapy-based biomarkers to select patients for neoadjuvant platinum-based chemotherapy. So we have circulating tumor DNA, which needs more exploration in the perioperative space. And then we have a series of tissue-based biomarkers that honestly have been underwhelming. So I think it's fair to say at the moment we're selecting patients who are fit for therapy, not based off tumor biomarkers. So when one thinks about the practical considerations of using perioperative therapy, I'm going to start with chemotherapy, if I may, because that's the standard treatment until very recently. Clearly, platinum eligibility has been an issue. Now, the creatinine clearance is important there. In the Niagara trial, we were able to split the dose of platinum-based chemotherapy and go to creatinine clearance of 40. And I think in the subset, the forest plot analysis, we could see that the benefit was for both groups of patients. So I don't think splitting the platinum makes any difference, but it does increase the patient population. So that's the first question to ask, I think. I think the second question to ask is, does the patient want to have a cystectomy? And are they fit enough to have a cystectomy? My experience of that is most patients who are fit enough for platinum-based chemotherapy are fit enough for a cystectomy. And then in the current era, what about immune checkpoint inhibition? The Niagara trial tells us the combination of cisplatin-based chemotherapy and in combination with durvalumab is associated with disease-free survival and an overall survival benefit. The contraindications for immune checkpoint inhibition are quite specific, actually. Active autoimmune type diseases, patients on immune suppressive therapy. These are contraindications. But the majority of patients, again, who are fit enough for cisplatin-based chemotherapy or fit enough for cystectomy are easily fit enough for single-agent immune checkpoint inhibition. And indeed, I think it's fair to say, of the three interventions, cisplatin-based chemotherapy, 4 cycles, cystectomy, and immune checkpoint inhibition, you could easily argue that the immune checkpoint inhibitor is the easiest of those three to give by some distance. Don't get me wrong, associated with significant life-changing toxicity in a small percentage, but for majority of patients, well tolerated. I've been talking recently about whether or not we're going to be able to cure large groups of patients with urothelial cancer. When I started this talk, I talked about the majority of patients having a cystectomy in the 274 trial relapsing within a year. And that's a really poor outcome for what we think is, that's the control arm, by the way. It's a really poor outcome for patients, for those patients who we told actually with curative goals. But I actually think we are going to cure a lot more patients. What I think is really exciting that's going to come to the forefront in the near future are a series of subsequent big randomized phase 3 studies with similar designs to the Niagara durvalumab trial. And we have trials like KEYNOTE-866, which is Gem-Cis Pembro, Energize, Gem-Cis Nivo. We've got the SWOG study here, which is also an exciting trial. But I wanted to highlight the EV Pembro and EV Durva Tremi trials in the neoadjuvant space as well, because I suspect many of those trials that are doing gem-cis plus immune checkpoint inhibition will have similar results to Niagara. I suspect they'll have more similarities than differences. But there is a possibility that the EV-Pembro and the EV-Durva-Tremi trials, which are compared to either chemotherapy or cystectomy alone, have the opportunity, in my opinion, to be transformative. I think this is such an important question because we've worked in silos in the past, and we still do to some extent work in silos. The surgical team has surgery clinics. Their surgical clinics have spectrums of patients with urothelial cancer, many with early disease, TA, requiring repeat cystoscopy. Some have requiring intervention with non-muscle invasive bladder cancer, and other patients on long-term follow-up for previous muscle-invasive disease. Previous non-muscle invasive disease. Muscle-invasive bladder cancer, though, is a multidisciplinary specialty, and it requires, at our institution, and I think most institutions around the world now, oncologists, both radiation oncologists and medical oncologists, and the surgical team and the research teams, I hope, working together. It's very important that that takes place because I do feel the role of cystectomy, which at the moment has been the mainstay of treatment. I say to my patients, neoadjuvant chemotherapy is only the icing on the cake. But I think the durvalumab data changes that a little bit. I think getting immune therapy in really early to these patients who have more than a 50% chance of, of things going wrong one way or another, I think early immune therapy makes a big difference. I think giving chemotherapy, doing cystectomy, and then getting it only then speaking to the oncologists and giving adjuvant therapy. I think for many patients, that's going to be 16 or 20 weeks after they were first diagnosed. You've got to go through the chemotherapy, have a cystectomy, recover from the chemotherapy. The drug, the chemotherapy, the systemic therapy drug that I think is making the big difference, the big term, long-term difference, is the immune checkpoint inhibitor. And that's why it's my preference to get that drug in sooner rather than later. And therefore, we're going to have oncologists and surgical teams working more closely together.
I'm Lindsay Diamond. I am a GU nurse practitioner at Mount Sinai Hospital in New York, where I oversee clinical trial operations and nursing development. It's always important to start with relaying important up-to-date education, possible immune-related adverse events, and mechanism of action, not only with patients and their caregivers. Immunotherapy works very differently than traditional chemotherapy, and there is historical stigma about chemotherapy and the side effects that come with it. So we want to make sure we're breaking through that up front before we get into any deep dive into education about immunotherapy. The therapeutic responses, the adverse events are very different. Particularly that immune-related adverse events can really affect any organ or any system in the body. And the timing of the immune-related adverse events can be a bit less predictable than with standard chemotherapy, with the potential for adverse events to continue even after discontinuing treatment. So when new drugs come to market, or even when existing drugs are now being used in a different disease or a different space, we really rely on their clinical trials as an aggregate of data for what we might see in the community. Sometimes you can pick and choose some of those adverse events that might be more prevalent in the community, but typically it doesn't translate directly because clinical trials are in a much more controlled patient population. However, I will say that when looking at Checkmate 274 and IMvigor10 and Ambassador, we're using 3 different drugs. The side effect profiles for any grade adverse events are exactly the same, and it is also what we are seeing in the community. So this makes it a little bit easier for us as we integrate new drugs into the community because it gives us a more concrete base for our patient education and what to be looking out for. So we know that most patients are going to experience pruritus and fatigue and diarrhea. That's talking about any grade. So that could be grade 1, grade 2. We're just managing with supportive care. But it allows us to educate patients of what to expect. So there is a difference, though, of what are expected side effects and what are acceptable side effects. So while we expect pruritus and fatigue and diarrhea, what's an acceptable level of those adverse events is going to be highly personalized to the patient in front of us based on their quality of life, risk benefit, preferences, and ultimately their baseline. So while all 3 trials are using different drugs and their any grade side effects are similar, it's important to note that grade 3 or higher adverse events in the different trials were a bit different. So when looking at Checkmate 274 with nivolumab, we saw increased lipase and amylase in those patients, although the clinical significance of that is unclear if they were asymptomatic. And there was also diarrhea noted, grade 3 or higher. When looking at IMvigor10 with atezolizumab, there was a prevalence of arthralgia, as well as ALT increased and colitis. And then as we move over to the Ambassador trial with pembrolizumab, again, we see that increased lipase level. We see grade 3 or 4 diarrhea, and then we also see grade 3 or 4 fatigue. Another consideration is when we are giving immunotherapy in combination with chemotherapy, as with the Niagara trial, you're now giving different drugs, different classes with different mechanism of actions, different half-lives, different side effect profiles. So it becomes a bit more complicated in terms of what to expect, how to kind of figure out which drugs might be causing which side effects, because that's ultimately going to change your management. In the combination therapy in the Niagara study, we see an increased grade 3 or 4 neutropenia, urinary tract infection, and anemia. So as a nurse, of course, the core is always education. There are studies that show that patients retain about 30 to 40% of the information that you give them in a visit. So what are the things I really need them to retain? I, again, need them to understand what are some expected common side effects, but also what are the warning signs that I need to know about immediately. My rule of thumb for patients is always anything new I need to know in real time. Even though it might be mild diarrhea or a mild rash, let us as the professionals, let us as the experts be the one to collect that data, analyze the data, be able to see what the change might be from baseline, how quickly are things progressing, and let us bear the burden of deciding how to manage those side effects. We never want to put that on the patient. We never want them to feel like they can't report a side effect until they come back, 4 weeks or 6 weeks later. So my rule of thumb across all patients for all treatments is the second there is a new side effect, I need to know in real time. It allows us for early identification, early management, early intervention to ideally prevent, when possible, those adverse events from becoming a grade 3, becoming a grade 4, or getting to the point where we need to discontinue therapy. We want to be able to manage these patients and keep them on drug for the duration of their planned treatment. This includes education with the patients, either verbally and in writing, incorporating friends or family in the conversation, and making sure they have the resources of where to go if they need additional information, who to contact after hours, over the weekend, right? We want them to be able to access information, access support in real time as soon as possible. We also want to make sure as clinical professionals, we are doing our due diligence in routine screening at baseline. So making sure we have a thorough assessment of the patient's medical history, their physical exam, blood work at baseline, so we can identify any abnormalities that might become problematic, but also B, just to have a good baseline to help identify if there's going to be changes. We want to make sure we're working up any medical history or physical exam abnormalities that might become problematic. So if they maybe had a history of irritable bowel, we might want them to see a GI specialist before starting on treatment. If their CT chest shows potentially inflammatory changes in the lung, we might want them to be cleared by pulmonary before starting. So we want to make sure we're doing a really thorough baseline assessment of these patients to help either predict adverse events that might develop, but also help identify any changes along the way. And lastly, we just want to make sure we understand that side effects can involve any organ or any system in the body. Again, you're tailoring your education to your patients based on, their health literacy, their desire to retain information. Some patients are like, read me every single side effect from the package insert, and some are like, just tell me what are the important things I need to know. What we try to tell our patients is the potential of any itis in the body. And we try to explain, a colitis would be an inflammation of the bowel. A pneumonitis would be an inflammation of the lung. There's the potential to develop an itis anywhere in the body, and it's going to present differently in every patient. So your job as the patient is to just let us know anytime you're developing a new symptom and let us kind of work through what that itis might be. So again, with most drugs, the earlier the identification of an adverse event, the earlier the intervention, the best chance you're going to have of preventing that adverse event from becoming severe. So the sooner we can identify a rash, the sooner we can proceed with supportive measures or maybe topical steroids and prevent that rash from becoming to a grade 3. However, we know that it's not possible to prevent all adverse events from progressing. It's just the way that the drugs work. So we have guidelines for how we manage immunotherapy toxicities, such as CITSI and ASCO. So often when adverse events become refractory to supportive care or non-interventional medications, the first step is going to be systemic steroids. That's often our first-line treatment, although there are some patients in some cases where their adverse event becomes refractory to steroids and they're going to require other immunosuppressive therapy. We're going to want to interrupt treatment for grade 2 toxicities while we're managing them. And if a patient does develop a grade 3 toxicity, we should be referring them to a specialist. So whether that is a dermatologist for a rash or an endocrinologist for hypothyroidism, we want to make sure we're getting additional specialists weighing in on these patients. And then in general, if a patient were to develop a grade 4 toxicity, we're going to want to discontinue treatment. So the multidisciplinary team is incredibly important. So you have the multidisciplinary team that's going to be within your oncology practice. So you're going to have a physician, a nurse, an advanced practice provider. You might have social work, nutrition, but then it expands beyond that practice. So we need to make sure we're building a community of experts that know how to diagnose and manage adverse events related to immunotherapy. This is becoming a little bit less difficult now as immunotherapy is kind of becoming more expansive through multiple different cancers and stages, but especially for those that are treating patients in the community that might be using immunotherapy less often, you want to make sure you have easy and timely access to different specialists, especially when you are using immunotherapy in combination with other drugs like chemotherapy, where you really need help deciding or differentiating which drug is causing the adverse event, because that's going to change your management. Regardless, you want to have a GI expert that can see patients for a quick colonoscopy if you're concerned they have colitis. You want a dermatologist that would be able to do a skin biopsy for a progressing rash, and that also have the tools and the resources and the team available to help with those advanced treatments for those adverse events should they go beyond the need for steroids. So it's important in a large institution to manage these patients, but it's becoming more and more important as these drugs are given in the community to ensure we have built those relationships with providers that our patients can see. So like I mentioned earlier, I think the start of the conversation is always, how is immunotherapy different than chemotherapy? With historically, cancer equals chemo equals feeling really sick. And being able to break through that stigma of anti-cancer therapy, discussing how immunotherapy works, and how those side effects are different because of that, is going to be the first step. We want to make sure we're setting patients' expectations, not only in terms of side effects and how they might feel, but also how it might impact their quality of life. What does the treatment schedule look like? How often are they going to have to take off of work to come in? If they don't feel well and they live a couple hours away from their main provider, can they seek care locally? So this is all part of the upfront patient expectations. the physician is likely going to discuss treatment options, but oftentimes the doctor leaves the room, the nurse comes in, and this conversation comes back up again. So talking about the different treatment options, why they maybe can't or shouldn't get chemotherapy in this space, and again, the lifestyle adaptations. Historically with chemotherapy, there is a lot of fear of I can't hug my grandkids, I have to flush a toilet twice, all of these lifestyle modifications that are going to roll into your conversation about immunotherapy. And you lastly want to make sure your patients have access to all appropriate resources. Obviously, they're going to have access to their care team, they're going to have emergency numbers, but sometimes they need others to talk to that aren't medical professionals. So a social worker, maybe a support group, sometimes connecting them with other patients that have gone through a similar journey.